This is Healthcare Today with your host, Kelly Roberts.
Welcome to Healthcare Today. In today's show, we are going to highlight area centers that treat cancer right here in Southwest Georgia. I am first joined by Dr. Eric Anderson. Welcome.
Well, thank you.
And we are here at the Perlman Cancer Center in Valdosta, Georgia. We appreciate you letting us come today.
Well, thank you for having me.
Now tell me a little bit about the Perlman Cancer Center here.
Perlman Cancer Center has been here just shy of 20 years now. We've got one radiation oncologist, two medical oncologists. It serves Southwest Georgia, North Florida. We get referrals from as far away as Brunswick and Jessup and several hours away. And we provide comprehensive care of all adult cancers.
Okay, and recently y'all won some awards for the center.
That's right. This is the third year we've won a Women's Appreciation Award for women's health care.
And you mentioned it's comprehensive care. Talk to me a little bit about that.
Yeah, that's kind of from beginning to end. So from diagnosis to, we have surgeons in town that help us. They don't work here at the cancer center, but we work in conjunction with them. And then once they're diagnosed with cancer, they come here and see the radiation oncologist, the medical oncologist. They see the dietitian, they see our social workers, we have financial planners, and basically from beginning to end, we're taking care of their cancer, treating, helping them go through this process, whether it's to prolong their life or whether it's to try to cure them.
Cancer is the second leading cause of death in the U.S. I mean, just in your time of practice, do you see that continue to increase, unfortunately?
Absolutely. As we talked a little while ago, this is my 15th year here in the Valdosta area, and so I'm close and just a few degrees away from almost everyone that has cancer in the community, and I'm from here originally. And so as you see the population aging, especially the baby boomer population now getting into their 70s and 80s, you're seeing a higher rate of cancer, not only in the community, but obviously across the nation. And the important part and the sad part of this is a lot of them are preventable. And so we see a lot of cases that if they would just followed up with their primary care physician and gone through the proper screening procedures, which I'm sure we'll talk about, they could have been prevented or caught at such an early stage where it wouldn't have been a life-threatening issue.
And let's talk about when someone does get that difficult diagnosis. First of all, it's overwhelming. They've been diagnosed or they've heard the word cancer. What do they need to arm themselves with when making a choice and a decision and trying to figure out what is their best place to get treatment care?
I mean, obviously information is key, and you got to be careful because people will come and see me and have been on the internet for a week or two or a couple of days. And then you also have family members and friends kind of come out and give their opinions too. So I think the best thing to do is sit down with an oncologist, talk about the type of cancer you have, what the prognosis is, and what are the options. I think as a patient, you should be armed with all the information to make the right decision for you, which is different for people. I mean, some people decide not to take any treatment. Some people want to do everything they possibly can, and then talk about options such as clinical trials. Is that the best thing going forward? And I think you can make that decision with your family, with your husband, children, and with your caregiver, the oncologist, radiation oncologist, with a social worker, and kind of figure out what's best for you. Once you're seeing us, it's obviously you've been diagnosed with cancer, you're undergoing treatment, and obviously a lot of situations it's not a curable cancer. So the key is catching cancer early or preventing cancer, and that's where following American Cancer Society guidelines or different organizations' guidelines are important, especially with mammograms, colonoscopies, skin screenings. That's where the primary care physicians are extremely important about being kind of the gateway to catching these things early, but it takes a patient being compliant, showing up with the physicians and going to their appointments. So the biggest thing we stress is prevention. We do at the Cancer Center have several screenings throughout the year. We have usually 3 to 4 days in May where they do skin cancer screenings that are free to the public. We do other oral cavity screenings, and we do have some other female cancer screenings during the year. So if you go to our website, which is sgmc.org, they'll post those through the year, and they're free to the public, and they are held here at the Cancer Center.
And that's probably something people take for granted, are the skin. So let's talk a little bit about skin cancer. Do you see a good bit of that you treat?
We see a good bit of it, and most of the skin cancers are taken care of by the dermatologist. You see us if it's spread.
Right.
But the key is any change. And I tell my patients that with almost anything. Any change for you is a new change we want to know about. So if you notice any mold changing colors, anything you're concerned about, please have a physician or a practitioner take a look at it, refer you to dermatologists if needed, and a lot of those are curable when they're caught early.
Okay, and I think what goes hand in hand with this, how important is knowing your family history?
It's very important. There are a lot of genetic conditions now that can predispose you to cancer, so that's part of prevention. If you have a family history, especially with, the most common people hear about is breast cancer, because you have several famous people through the years that get diagnosed with these genetic conditions, and all of a sudden it's in the public consciousness. If you have a family history of cancer, it's good to discuss that with your physician, because there are genetic screening tests that we do. We have patients referred over just for genetic counseling. And there's obviously some issues with genetic counseling from a psychological standpoint, emotional, as well as a physical standpoint, and we go over all that with the patients, and then we send off blood tests that look for genetic conditions.
Okay, and what does that, if they do they're predisposed, at that point, do you have a plan of care?
Exactly. It depends on which, there's a whole host of genes we look at, but for example, what's called BRCA mutations that lead to breast and ovarian. If you have one of those mutations, you have anywhere from a 60 to 80% chance of breast cancer. So then you're left with some decisions. Do you have surgery up front to prevent, or do you take a medication to prevent? And we go through all that with the patients once those tests return.
We hear often clinical trials, and that's kind of broad. Help me and viewers understand a little bit about those.
Yeah, clinical trials, it's a very broad spectrum when you're talking about clinical trials. That can go from taking a medication where you don't know if it works and what the side effects are, and those are what's called either early preclinical trials or phase 1 trials, and those are only done at university settings. Right. We participate usually in phase 3 trials, which means we have a medication that we know works in the cancer and it's being compared to the standard of care or the available treatment. Clinical trials are extremely important. The breakthroughs you see with melanoma, for instance, Jimmy Carter's on the news for taking an immunotherapy drug, and he's in his 90s. That drug only came about through clinical trials, and we participated in one of the clinical trials that led to a different drug being approved. All those clinical trials are extremely important, and the physician can kind of, there are patients, if I saw you, for instance, that depending on the type of cancer you have, that may be the best option for you up front. It may not be an option down the line. It may be what we want to do up front, and we find either the best place for you to go, or if we have the clinical trial here, we'll talk to you about it and give you those options.
It's a great advancement with medicine, I know.
Absolutely.
You see. Real quick before we go to the next break, I just want to reiterate, screenings are important.
Absolutely.
You just
screenings are, that's the number one thing you can drive home. It's one thing to come talk to an oncologist about treating cancer, but if you can prevent it or catch it early where you don't need anything afterwards, obviously you're in better shape.
Well, great for information. I appreciate you taking the time today.
You're welcome.
Stay tuned and we'll be right back.
We start little and the world is new. We begin to grow, and sometimes we need help. So it's a breath of fresh air knowing SGMC is here for me, no matter what comes my way or how many birthdays I celebrate. SGMC is focused on providing quality patient care and has received numerous national awards for medical excellence, with locations in Lakeland, Homerville, Nashville, and Valdosta. SGMC, growing healthy together.
Welcome back. Now I'm joined with Patsy Martin, breast cancer survivor right here in Albany, Georgia. Tell me a little bit first about when you were first diagnosed.
Well, several years ago, I had repeat mammograms, and I had them over the course of 9 months. I think I had 5 mammograms. So I knew that there was something suspicious, and the radiologists couldn't seem to find what was going on, but they knew the tissue was changing. So we had an ultrasound, and I went to the surgeon to get the results of that, and sure enough, I was diagnosed with breast cancer. It's a scary thing. That C word is a big, scary thing, and I just couldn't imagine going through a journey like this because I'd never had any breast cancer in my family. I wasn't a smoker. I didn't do any of those things. I had had cysts and lumps and those kind of things over the years. But it was, in fact, breast cancer. I was eased tremendously because my surgeon sent me to this wonderful man named Dr. Sharad Jani. I'd heard of his reputation, but when I walked in that office, I just can't even express to you the comfort that he and his nurse Alberta brought to my daughter-in-law, and me. But I would recommend the Phoebe Breast Cancer Center to anybody. Do you realize that we have here second opinions every single week, and many of those second opinions will drive from Atlanta to be treated by the Phoebe Breast Cancer Center here.
Thank you for sitting down and giving us your time.
Oh, absolutely.
Telling your story, and hopefully you've encouraged others to continue with checks.
Great, I hope so. It's
Thank
a pleasure.
Okay, thank you. Stay tuned and we'll be right back. Welcome back, and I'm now on location at the Phoebe Cancer Center, and I'm joined with Dr. Robert Kwawicki. Thank you for being here.
Thank you.
Cancer awareness is something we're covering in today's show, and we want to make people aware of all the cancer treatment and options that are available right here at Phoebe Putney. Talk to me a little bit about that.
Yes, we're a comprehensive cancer center, and we see a variety of cancers. The most common are the most common that you hear in the country: breast cancer, lung cancer, colorectal cancer, prostate cancer. But we're also involved with a number of what they would call liquid tumors, from acute leukemias to chronic leukemias to a type of bone marrow cancer called multiple myeloma to lymphomas. So we treat a whole array. And there's 8 my colleagues here, and have a number of strengths with covering all those types of cancers, the ability to treat them here and keep people local in most cases.
Okay, and it doesn't just stop or start with just the treatment and diagnosis. You carry the patients through this entire journey, is that correct?
That is correct. We would continue depending on whether it's a curative intent or palliative intent, meaning we can't cure it, but we can continue doing treatments to keep people alive and keep them in the best quality of care that they can have for what type of cancer they do have. And also now we're getting into what's required by the Commission on Cancer on patients who are survivors of cancer and been cured, of survivorship programs that we outline what we're supposed to do, what should be done after a person has completed their treatments to go forward, such as how frequent should they be seen, should they have any studies, including scans done, what long-term effects from the therapies they've had should we be looking for, and et cetera, like that.
Okay, and I know you mentioned you have navigators that help coordinate their care.
Right, we right now have navigators in 2 areas, lung cancer and breast cancer. We'd like to expand this to others, but for example, if a person comes in with breast cancer, the navigator gets involved with them right from the beginning and helps them get through the whole program to who they need to be seen, from the surgeon to the medical oncologist to potentially the radiation oncologist. Also, if we have to get them through programs for hereditary cancer screening, if it falls into that. Also, what programs they may need for assistance. We have a great social work service here to help them with their additional needs.
Okay, and that's great because they've established a relationship with someone that can get to you should they need you or have any problems. And speaking of hereditary, family risk, we've been told, plays a huge factor in several cancers. Yes. There's no cancer that's excluded from that. Is that correct?
That is correct. The exception may be, to some degree, lung cancer. That's more of what exposure to, but some people may have more chance of developing, again, because of hereditary risks. But the more common ones that we know that about that we're really screened for right from the beginning are the breast cancer and colorectal cancer, but there are many others that would fall into that realm. And that's where we have, with partnering with a company called Myriad, that we have a hereditary cancer questionnaire that all patients will fill out, and then we screen this, and we have a specific nurse dedicated to reviewing all that information and then contacting the patients about coming back in to meet and discuss about their family background and about potential having the genetic blood testing done.
Okay, great. This is great information. We're going to take a quick break. Stay tuned and we'll be right back.
If you're a health professional and would like to learn more about becoming a guest on Healthcare Today, please contact Kelly Roberts at 446-4074 or email her at kelly.roberts@waob.com.
Welcome back, and once again I'm on location here at Phoebe Cancer Center. I'm now joined with Dr. Johnny. Thank you for sitting down.
Thank you for the opportunity.
Okay, and Dr. Krawicki previously was telling us about all the different types of cancers you treat right here. But one thing I'd like for you to talk to me about is the accreditations and the awards that Phoebe's won.
Well, so we are a big believer that the best in us is not good enough and we want to be better. So we want to strive harder and work more to get to a level where we get and provide excellent care to our community and the patients around us. So the accreditation provides us with a platform to provide the best quality care, which is patient-centered and in a multidisciplinary way. So that's what all it's about. The accreditation we have at Phoebe is nationally recognized, which is Commission on Cancer National Accreditation for Center of Excellence, which is called NAPBC, and American College of Radiology.
Okay.
Now, this accreditation are nationally and internationally accepted by not only the Medicare, Medicaid, and CMS, but also the National Quality Forum and the international organization. So it actually provides us with the platform where we can provide the best care to our patients.
Okay, and let's talk in detail a little bit about that care. I know that you are extensive with research and clinical trials. What does that mean for patients right here in Southwest Georgia?
So there is a national investment from the government as well as the National Cancer Institute about investing and injecting all the resources we can to provide the best quality care. And if you look at the milestone right from 1949, which was the first chemotherapy given, up until now, all this surrounds, it could not have happened without the research. So there are different type of research trials which goes on, and as a matter of fact, this coming week we are now partnering with National Cancer Institute in a forum called NCORB, which we have just signed the paperwork to access to all the clinical trials, which can range from screening all the way up to the treatment to the symptom control, so we can take care of the patient as a whole.
So does this give you, this obviously gives you better treatment options when a patient comes to you? Because I would imagine no two cases are the same.
Absolutely. So because there is so much of research going on nationally and internationally, without access to the clinical trials, it's very hard to provide the cutting edge treatment. So though there are accepted treatment, the things are happening on daily basis, and through this access to the clinical trial, we can provide the best of the care we can.
Right, and we spoke to one of your patients earlier, and she had just great things to say about you and the care that she's received, and mostly about this journey. And Dr. Krawicki talked a little bit about that. So you give the patient care as a whole. Is that correct? Do you have a good follow-up plan when they finish treatment?
Absolutely, and there are certain programs in place which are actually at the national level, which includes the totality of the care, which includes survivorship, navigating the patient right from diagnosis all the way up to the treatment, end of life care, which is hospice and palliative care, as well as we have something called survivorship. So after all the treatments are done, there are still a lot of psychosocial issues, navigational issues, spiritual issues which still need to be addressed after the treatment, and that's done through our specialized program, which are called navigation program, survivorship program, palliative care program, which provides the comprehensive care in a multidisciplinary way.
Okay, and then you also have a lung watch program, is that correct?
Absolutely, that's a part of lung cancer screening. So just as we have mammogram for breast cancer, there's something called low dose CTs which can detect early cancer, and actually the program we have is almost like a national international program which is second to Leahy Clinic.
Thank you for your time.
Well, absolutely, thank you.
Stay tuned and we'll be right back.
If you're a health professional and would like to learn more about becoming a guest on Healthcare Today, please contact Kelly Roberts at 446-4074 or email her at kelly.roberts@waob.com.
Orbera is the latest innovation in non-surgical weight loss. Orbera is proven to help you lose 3 times the weight of diet and exercise alone. The Orbera procedure is now available at Colquitt Regional.
Welcome back. I'm now on location here at Colquitt Regional Medical Center in Moultrie, Georgia, and I'm joined with Dr. Amber Holt, a general surgeon here at the hospital. Thank you for sitting down with me.
Sure, thank you for having me here.
We're talking about cancer awareness, and I know one thing that's huge is breast cancer, and you see a lot of that in your day-to-day treatment.
Yes, I do.
So I want to talk first about who should be concerned about breast cancer.
Sure. Well, really, every woman should have it on their radar. You know, unfortunately, in the United States, 1 in every 7 women will be diagnosed with breast cancer, and so it should be something that every woman thinks about.
Can you tell me what the current recommendations are for breast cancer screening?
Sure. Currently, we're still recommending that every woman at age 40 does receive a screening mammogram, and every year after she should follow with another screening mammogram. If there's something that comes up abnormal along the way, we may change those recommendations in her particular case, but the overall recommendations is at age 40 and every year thereafter. Now, for special cases when a patient's mother or sister or first-degree relative has been diagnosed with breast cancer, we generally start screening sooner in that woman.
Okay, and that first mammogram, is that what y'all consider like a baseline?
It certainly is. We will compare years prior or years after to that first mammogram.
So that's really important to have at that age, the baseline. Okay, and then now if someone, let's say they've not reached the age 40 yet and they feel like they found a lump, let's talk about what they should do.
Absolutely. This is something that I see pretty regularly in my practice. A younger woman will come to me with a complaint of a breast lump. That's something that's new. Important for her to be seen by her physician, and her physician will oftentimes refer her to a surgeon for another exam. The difference with finding a lump is that we're going to do probably a different imaging. In a younger woman, we like to use ultrasound as a baseline imaging study, and especially for palpable masses, ultrasound is a very effective tool. This also would go into self-breast exam. Do we do self-breast exams anymore? It's not part of the real national recommendations at this point in terms of locating a cancer, but it is important for women to know what their breasts feel like normal.
Say a patient does get a call back and now they've been given the word they have an abnormal mammogram. Let's talk a little bit about that.
Sure, that can be a scary moment, of course, when the radiologist calls you and says, I'm sorry, you've got an abnormal mammogram, we need to see you back for more imaging or you'll need to see your doctor. Most of the time, that's how I meet my patients, is by a referral from either the radiologist or the primary care physician for an abnormal mammogram. Now, that can be a scary time for the patient, of course, but it's I take that as my opportunity to really do a full exam, to get a full family history, to look at all the imaging and decide what do we need to do. And that's something that I can discuss with the patient in my office at that evaluation.
Okay, and then from there you'll decide their course of plan of care, whether they need a biopsy or...
Exactly. Sometimes it's something we can watch with, serial imaging. Sometimes it's things that we need to biopsy. And we can discuss that depending on what it is. Okay. But in terms of the biopsy now, the technology has changed so much that we have so much to offer in terms of minimally invasive breast surgery. It doesn't always require a large incision to get a sample of tissue. We can use ultrasound guidance and vacuum-assisted or suction kind of biopsies. We can use stereotactic with a mammogram biopsy, which really make it simple, easy, under local anesthesia rather than general anesthesia these days, and we've come a long way with the technology.
Okay. So with that advancements in the breast biopsy, like you said, it's more detailed for the patient, needle-guided biopsies, things like that. So does that help the patient get a faster turnaround for results?
Well, I think so. You know, here at Colquitt Regional, we try to get our pathology back within 2 days, and that allows me to really call the patient with hopefully good news, or get them back into my office to quickly plan for the future.
Right, and that is something that you set up, you do that in your office? So
in my office at the initial valuation, absolutely.
Have a lot of downtime between getting that news of needing something? And
no, absolutely not. And especially with a breast patient, when I get a call for an abnormal mammogram, I try to work them into the schedule pretty much within that 1 week, so that we get them seen quickly.
Walk me through what happens next for that patient.
You know, this is sometimes the hardest part of my job, is to discuss this kind of a thing with a patient. But I like to bring the patient into my office. We have a full discussion about what the cells look like, what's the size of the tumor, and what's the course of action ongoing. I kind of take my time with the patient to plan their course of action. Like I said, we may be able to do this with a lumpectomy through a small incision next to the areola, which doesn't change the patient's look at all. It may require more surgery than that. But I kind of give an idea for what the options are. We lay out a plan, and then I put the patient into contact with the plastic surgeon if necessary. With the medical oncologist, the radiation oncologist, and I walk them through their care. I'm not the first person that they see in the road of their cancer story. I'm usually the first and the middle and the last, and so I'm seeing them at every step of the way.
A lot of people may feel like, you know, I have no family history, you know, I'm young, I don't, you know, I might not get it at 40, I'll probably wait till I'm 45. What do you have to say to those patients?
I can totally understand where you're coming from, but we know that the statistics are what they are. 1 in every 7 women, and that's not women with an increased risk, that's women of average risk. And so it's so important to find these tumors when they're small. You know, that's the one thing that's really hopeful about breast cancer in many cases, is that when we find a small tumor on a mammogram that's not even a palpable lump yet, we can treat that cancer, we can cure that cancer, and those women go on to live normal, healthy, long lives. We hate to find a cancer late in its stage.
Let's just say somebody does not have a physician or has not been established. Do they need a physician referral to get a mammogram?
At Colquitt Regional Hospital, you do not need a physician prescription to get a mammogram.
Okay.
We do allow walk-ins for mammography for every woman over age 40 from 10 o'clock until 2 o'clock, Monday through Friday.
Okay, great. Let's talk about what are some of those risk factors.
Well, it depends on each patient, and I'll calculate their risk with them when they come into my office using a Gale model, and you can find this online these days. But it has to do with your family history, your own history, prior breast surgery for lumps and bumps and other things like that.
Okay, is there anything someone could do to maybe lower their risk?
Absolutely. A lot of research is coming out now about risk reduction and recurrence prevention, and this is due to diet and exercise, really. Lowering the fat in your diet and getting out and walking for 30 minutes a day, 3 to 5 times a week is all it really takes, and you can reduce your risk of breast cancer by up to 15%, which is significant. And if you've already survived breast cancer, you can reduce your risk of recurrence by the same thing.
Some great information today, and we again want the take-home piece to be for screenings. Get screenings.
Have a screening, take your mother with you, take your sister with you, your 40-year-old daughter, take her with you. It's so important because breast cancer is a curable cancer, technically speaking, when we catch it early in its stage. And so this is the best method that we have. It's very much available in our area, which is wonderful.
And I want to point back out, everyone is at risk. There is no one that can escape this.
That's right.
1 out of 7 women, that's a strong statistic.
It is, it really is.
Okay, well thank you for your time and thank you for being here.
Thank you so much, I appreciate it.
Thank you for watching Healthcare Today. Remember, it's so important for you and your loved ones to be screened. Cancer is the 2nd leading cause of death here in the United States, and screening and early detection is key. Thank you. We'll see you next time here on Healthcare Today.